now I'm going to move to the other area. I've chosen areas of interest because I think the odontogenic things, I think we're all fairly comfortable with. So I'm choosing areas more in head and neck pathology, the challenging cases. So let's talk about nasopharyngeal masses, because I look at a lot of CT images, and all I know sometimes that there's a mass obstructing the sinonasal complex. And it could be somewhat papillary, but until you actually see it histologically, it's very difficult to know what this is. And I have a whole presentation on sinonasal masses, and I take my learners all the way from sinonasal polyps to allergic polyps to benign papillomas, hamartomas, to things that have an adenocarcinoma appearance, to high-grade adenocarcinomas, all the way to high-grade small round blue cell tumors that you have to figure out, are those melanomas, are those sarcomas, are those lymphomas. So I want to start you, I'm going to show you some of the high-grade lesions here. So it shouldn't be too much of a surprise that this is a blue cell tumor that shows up as a polypoid mass in somebody's cavity. So blue cell tumors can be very, very challenging to diagnose. But there are some features here that we can look at as we go from 20 to 100 to 200. And the first thing is that there do appear to be maybe attempts to either make glands, or are those some sort of rosette type structure. So now I can think, do I have an adenocarcinoma? It's going to be high grade if I have it. I can see the nuclear features are very large. Some of them are very hyperchromatic. Or do I have some kind of high-grade neuroendocrine tumor that may be having some kind of bizarre pseudo-rosette kind of thing? When I look at other areas, it's very solid, very sheeted. There's no intervening vascularity, so I can start thinking maybe this is not certain tumors. And when I look at this at very high power, this is a very high-grade tumor. It almost has sarcomatoid features to it. But when you look carefully, you will see that some areas do secrete a product. And you can kind of see they almost have a goblet cell appearance to them with a high-grade appearance. So I might start thinking about some kind of secretory tumor that's high-grade. So I'm going to put myself into an adenocarcinoma as I start thinking about what immunohistochemical or panels that I want to do. So when I look at other areas, I see spaces, but what I don't see are neuroendocrine nesting. I don't see the vascularity associated with some of the neuroendocrine tumors. But then I see very high-grade features. I see it streaming. I see some inflammatory components to this because of what it's doing. But I can get a sense that these might be epithelial cells that are surrounding some sort of space, or cystic or whatever. So I asked my learners, okay, what do you want to do next? So the way we tease this out, and this was not my case, this was actually another oral pathologist case, but by immunohistochemical stains, you'll see that it stains for a lot of intestinal enteric type stains, right? You'll see it has cytokeratin staining, it has villain staining, it has some CEA monoclonal staining. And the problem with these high-grade tumors is even these adenocarcinomas can pick up neuroendocrine features, right? As they lose their characteristics. That's what I find challenging and fun about the round or small or large round blue cell tumors is, okay, what am I going to find in the immunohistochemistry? So this turned out to be a very high-grade adenocarcinoma. And I apologize, I misspelled differentiated. Every once in a while, I mistype. So this one ended up being a very high-grade adenocarcinoma. Now, you can do one of two things. You can go investigate to see if the patient has an intestinal carcinoma somewhere else. This patient did not. So this is one of those essentially ITAC type tumors, but it's extremely high grade. The next sinonasal mass I'm going to show you is also a blue tumor. And so I'm showing you the blue tumors because I think this is the area that to the novice oral pathologist, or if you don't see a lot of these, I benefited by being in Long Island, and I saw a lot of head and neck, and I benefited by being in institutions where we had head and neck surgeons, ENT surgeons, who would send us these cases. So the first thing that should draw your attention is that there's bone in this that's being invaded and being destroyed. So now I have a high-grade tumor that's invading bone. And it's almost uniformly blue, but if you start to pay attention, you'll start to see some nesting of these tumor areas. And then you'll get a sense that there might be something intervening between the two. So I'm getting a pattern here that's different than my intestinal carcinoma. So I'm just showing you the 20x view so you can see how kind of fragmented it is, right? It's very difficult to tease this out. So now I'm going to start looking higher power. And what I'm going to start to see is that I have these cells that sort of seem to be sheets of certainly blue cells, basophilic cells. There are some spaces that we're going to investigate that look somewhat similar to the previous case. And when I start looking, now they're all sort of uniformly somewhat small and somewhat round and certainly blue or basophilic. And I do see some spaces. So once I have to ask, are these cystic spaces? Are they pseudo-rosettes? Is it fat? I'll have to investigate that. But then I start to see this very distinct pattern that we know happens in a subset of tumors with these large nested areas with an intervening stroma that will turn out to have they'll turn out to have small vessels. These are red blood cells. So very large nests with maybe pseudo-rosettes with a small round appearance. They can form sheets composed of the nests, but they still have the same. Then you have the sort of intervening background stroma that almost reminds me of neuropil. It's not collagenous. It's not mucinous. It sort of reminds me a little bit of the background of brain. Now, if you didn't know where you were, this is how you can determine where you are. So if I didn't show you this case and I could ask my resident learners, where am I? Oh, this is respiratory epithelium. So I think I'm in the aerodigestive tract. So I would ask my learners, what information can we glean from this? So what we did in this particular case is we did neuroendocrine markers, and this was actually an olfactory neuroblastoma, right? It has all those features, right? It actually has the nesting, it has the intervening stroma in some cases. It was positive for neuroendocrine markers. It has what might be described as spaces that you could consider as pseudo-rosettes. And so now you have all these sort of primitive blastemal tumors that can also overlap with high-grade carcinomas and sarcomas. So what it opens up is now I have to think about salivary and adenocarcinoma type tumors in the sinonasal complex, and I have to think about all these, neural type tumors, primitive blastemal tumors. I'll show you a third case of a sinonasal mass, and what's going to strike you about this one is it doesn't look very blue. This one looks a little bit more oxyphilic, and it's very difficult to tell in low power what kind of cellularity do I have. I just know it's polypoid. These were all sort of reported as polypoid or mass-like structures that were causing obstruction in somebody's sinonasal complex, with or without nosebleeds. So the first thing I'm going to do is try to look at a pattern, and what I'm going to start to see is sort of not quite a streaming pattern, but sort of patternless. And then I start looking at the cells, and now I start to see, okay, these are a little bit more spindled. They have large, plump, ovoid type nuclei. So, now I'm starting to think, am I looking at a mesenchymal tumor? Am I looking at something like a hemangiopericytoma? Am I looking at a sarcoma? And I have to start looking for nuclear features, which are not all that impressive here. And when I look at other areas, I will also start to see a little bit more of a loose myxoid background, but I'm starting to see more of this spindled. So now I have to start thinking, do I have benign or soft tissue tumors to include sarcomas? And I look at other areas and they're very cellular. And then I start looking at nuclear features, and some of these have this sort of neural look to them, right? These comma-shaped nuclei. So I can start developing algorithms in my head of what kind of immunohistochemistry might I want to do for this. Do I have something that reminds me of maybe smooth muscle? Do I have something that reminds me of something more neural in its characteristic? And I can start to select. And I also happen to have some vessels in here. So now I'm also going to add things like sinonasal hemangiopericytomas, glomeruloperycytomas. And now I can start thinking about some of those pericytic type stains or potentially some genetics. And then other areas are extremely cellular and have a little bit more of this eosinophilic, oxyphilic, collagenous background. So now I'm even more pointing towards I've got vessels, I've got spindle cells. Do I have some variation of hemangiopericytoma? So I would ask my learners at this point, what would you like to do as your panel? So based on the panel, this turned out to be a sinonasal hemangiopericytoma. So I have both benign and malignant polypoid masses that all present clinically the same way as obstruction. So how do I solve these cases? So the big debate, especially, we're not going to spend as much time on all the round blue cell tumors, but the big debate lately has been, is there a distinction between a sinonasal hemangiopericytoma / cholangiopericytoma and an actual solitary fibrous tumor in the organs or the soft tissues? And the answer is yes, because there are some differences. Even though they both stain for factor 13A, what we notice is that the cholangiopericytomas tend to be negative for the CD34 and STAT6, whereas the solitary fibrous tumors tend to be positive for the CD4 and 34 and STAT6. And it should not surprise you that these tumors don't have STAT6 mutations and these do. And some people say, well, is this just an academic exercise? How differently do these tumors behave? Well, the issue becomes not only do they behave differently, which they may or may not, but we're also going to learn that these tumors may have associations with gastrointestinal polyps. We know that for a fact. So while you get cross-reactivity, because if you were to think, oh, is this some sort of sarcoma, and you inadvertently do a TLE1, and you think, oh, do I have a synovial sarcoma? The answer is no, because they don't have the same mutation. So I think in these soft tissue tumors, if you don't get a definitive immunohistochemical diagnosis, then you're sort of obligated to sort of look at the genetics of these things. So that leads me to, do we have to investigate a tumor that we discover inside the sinonasal complex of the oral cavity for other mutations? The answer is yes, because cholangiopericytoma, along with nasopharyngeal angiofibromas and some papillary carcinomas, actually have CTNNB1 mutations. And what does that mean? That means these patients need to be investigated for familial polyposis. So what you may do is, in teasing out a sinonasal tumor, you may tease out somebody who has an undiagnosed premalignant GI polyp. And you could save a patient potentially from a colon cancer. So I think it's important to do that. As an aside, there are some salivary tumors that have CTNNB1 mutations, but they're not associated with GI tumors, they're associated with skin tumors. So we learn that. And then you add another mutation onto this. So what we're finding now, I think more and more of our soft tissue tumors are going to drive molecular analysis, next generation sequencing. Because if I have a small round blue cell tumor, that has one implication. If I have a soft tissue tumor in the sinonasal complex, that has another implication. They're all presenting the same way. And I'm not showing you imaging and radiology here, but I want you to close your eyes and paint a picture in your head of what is this going to look like on a CT? It's going to be an obstructive lesion, either filling the sinus, filling the nasal cavity, or in some cases, perforating through the cribriform plate or perforating through. So when we talk about those olfactory neuroblastomas and the Hyams classification system, the grading and staging, a lot of that is based not on the histology, it's based on actually, does it invade an additional structure? So I have to talk about that, because I think you have to determine which is more important. Since I showed you a neuroblastoma, I have to ask the question. I ask the question of my learners. When you're communicating to your staff or your surgeons, what you probably need to communicate more importantly is the staging, right? Does this invade outside the sinonasal complex? If I have a nasal tumor that invades through the cribriform plate, or if I have a nasal tumor that invades into the maxillary sinus or into the orbit, and it's a neuroblastoma, I've just staged it higher. right? I may now have a stage C or D rather than a stage A or B. And you'll see that that's portends a worse prognosis for the patient, along with some age, a dichotomous age range. So before I show brain tumors, I'll pause for just a moment and ask, does anyone want to discuss or anything on sinonasal tumors?
There is one question. Oh,
Sure.
actually, as soon as I find it. Yeah, okay. What panel of IHC markers do you recommend for blue cell tumors?
So I tend to think, okay, what are the round blue cell tumors? There's lymphoid tumors. So I will do at least a cursory lymphoid panel, right? So I've asked the hematopathologist 3, 5, 20, 10, and then maybe BCL2, BCL6, and maybe cyclin D1, right? Treat it like a lymphoma to try to tease those out. Then there are all the neuroblastoma type tumors. So I will probably add a few neuroendocrine markers. I'll usually do at least 2, like chromogramin, synaptophysin. Then you have melanomas. So I will do at least 2 melanoma markers, whether or not you want to do melon A or MART1 or MID-F. And then I think, okay, what else is also now turning out to be in this mix of small round blue cell tumors? So I've covered that. Neuroendocrine tumors. So you're covering that with your neuroendocrine markers. I think you have to consider high-grade epithelial neoplasms, including all these translocation-associated carcinomas. So probably a panel. And I was taught, don't rely just on your cytokeratin cocktails, because your AE1, AE3 will not necessarily capture some of the low molecular weight cytokeratins. So if I'm going to do an AE3, AE1, or a LU5, I will also probably do an 818 or a CAM 5.2. I'll do a panel of things. And then by choosing that, and this is in the literature as well, so you see which direction it takes you, right? So if it's positive for, say, lymphoid markers, but negative for everything else, now I'll dive a little more deeply into the lymphoid. If it's positive for melon A and nothing else, I'm going to probably go down the road of melanocytic markers. And at that point, I may also consider genetics, because we know now with melanomas, BRAF mutations, right, all these things will have potential therapeutic. I'm trying to think, is it ipilimumab, right, is one of the medications we can use to hopefully prolong the patient's lives a little bit with a melanoma. Does that help? We hope.
Yes, I'm sure it does.
Yeah, so think in terms of broad categories. Am I going to do what are my potential tumors, right? Small round blue cell tumors are poorly differentiated tumors. So I'm just thinking in terms of lymphoid, epithelial, sarcoma, neuroectodermal, neuroblastoma type cases, and from there you can tease those things out. And you can use the same kind of thought process with your sarcomas, right? I don't know a high-grade sarcoma. Is it smooth muscle? Is it skeletal muscle? Well, then do a smooth muscle and a skeletal muscle set of markers, and I think you'll tease those things out. All right, I want to show you some brain stuff. Now, this is areas I think are outside our areas, but I want to show you, as head and neck pathologists, sometimes we will get things associated with brain issues. So I'm going to start with a craniotomy case, and I'm going to show you at low power. I have no idea of the pattern here. I know there's some hemorrhage, and I know there's some blue cells on here. But I start to get a sense of, oh, that looks like epithelium. So, ooh, I have an epithelial tumor that's associated with a craniotomy. So I have some epithelial islands. Okay, so where am I? I'm on somebody's top of their head. Am I going to be looking at a squamous cell carcinoma? That's my first thought. Even at low power, I'm going to look at a carcinoma. As I start to go to higher power, okay, now I'm starting seeing an epithelial look to this. And now I can go look and it's like, okay, what is it about this epithelium? What are the features of this? There are some high-grade features here, right? There's hyperchromatism. There are very prominent nucleoli. There are variations in the size of the nucleoli and the nuclei, but its background, it's a carcinoma background. When I look at other areas, I see the same features with some hemorrhage. So I imagine this patient's having some sort of bloody surgery on their cranium. In other areas, I begin to see even higher grade features. Right now, if this is a carcinoma, is it now starting to show some spindle features? Is it losing its, notice this is not really producing keratin. So this is turning out to be a higher grade carcinoma. It's not a basaloid tumor, but it's a carcinoma with high grade features. Maybe there are some spaces here. Could this be some kind of glandular tumor? I don't know. It has a little bit of similarity to my sinonasal tumor. In other areas, I'm starting to see more sarcomatoid appearance. So I've got carcinoma, sarcomatoid carcinoma, right? Higher grade tumor. And then in other areas, it's really getting this sort of spindle type appearance with this very sort of spindled background. So I'm somewhere between a carcinoma and a sarcoma here. And in other areas, I have significant pleomorphism, very high grade features. What I don't see in the background of these lesions are things like bone and cartilage. So I'm not thinking about sort of carcinosarcoma in the context of, say, like a salivary tumor. So I'm thinking some kind of skin cancer. That was my first thought here. But then I'm going to show you other areas where it starts to look at wants to produce keratin. So where am I here? All right, I've got a carcinoma. Keratins are not necessarily going to help me initially because they're probably going to stain positive. I have some basal features, I have some sarcomatoid features, and then I have other areas that are sort of forming these nests and islands. So there is some keratin here. So it's trying to be a normal epithelial tumor, but it's very high grade. In other areas, I'm going to use the term transitional here. All right, because I was not the person that signed out this case. I'm going to use the term transitional here. And maybe you're all already starting to think, okay, where am I going with this? So my next question is, what do you do for a case like this? There's two questions you can ask. What's the immunohistochemical pattern? And number two, I always ask, for a high-grade carcinoma, does the patient have a carcinoma somewhere else? And in this particular case, the patient did. And so we found out the patient had urothelial cancer, right? That's a transitional carcinoma. And if you go look at urothelial carcinomas, they look like this. So the surgeon, the pathologist basically teased out two stains that did this for him: cytokeratin 7 and GATA3. So we talk about CK7 and CK20 as an immunohistochemical pattern to tease out, is it gastrointestinal? Is it pancreaticobiliary? Is it salivary? Is it skin cancers? When you have a combination of a cytokeratin positive GATA3, now I'm not a urologic pathologist, but any of us can go into a textbook, right? I have a bunch of textbooks behind me, and you'll see that combination fits with urothelial carcinoma. And so whenever you have a carcinoma, the first thing I do before I do any kind of diagnosis, whether it's oral or anything else, if I have a carcinoma sitting in front of me, I'm going to find out, does the patient have a cancer everywhere else? Because the first question I can answer is this a primary cancer or is this a metastasis? So in this particular case, because I had a high-grade carcinoma that did have some transitional features, then I think, what are my transitional cancers? Typically urologic cancers, and especially if it's a male. So what this patient unfortunately had is he had a urothelial carcinoma that not only metastasized to his lung, but also metastasized to his scalp and into his brain. So that's why he actually had the craniotomy. Right now, that's not going to be a long life for this patient. Right. I have a friend who actually had ended up having metastatic esophageal cancer, and he's dying of it. He's 44 years old, and he's failed all his chemotherapy regimens, but by having a diagnosis, you may buy these individuals some time, right? My friend was anticipated to die 2 years ago, and he's still with us. So we're going to probably get to spend at least one more Christmas together, which is really nice. Okay, so when it comes to urothelial carcinomas, this is just straight out, I pulled this out of the textbook, right? These are the immunohistochemical markers that will tend to be positive in urothelial. And what you'll see is a lot of them will overlap, right? They do tend to be dual cytokeratin 720 positive. Well, that's also true of some GI tumors, although GI will tend to be 7 negative 20 positive. So there's some very good articles that look at panels. But when you add GATA3, that's actually pretty good with a cytokeratin panel for in the context of urothelial carcinomas. We also know is that these tumors, more of these tumors are turning out to have PDL mutations, which has been a great finding for a lot of our next generation sequencing, because PDL1 positive tumors now have a therapeutic option, right? There's PDL1 inhibitors now. We use that. There's some of those for lung cancer. So that's probably some of the good news. And then you think, okay, what are the other urologic cancers? Prostate cancer. So PSA and NKX 3.1, those would be prostate cancer markers. So would Amaker. And then, PAX8 will be some of the renal cancers. So just some immunohistochemical panels will help you. So since I know people are starting to think, oh, what panels would you do? I wouldn't do any of these panels. I'd send this to the urologic pathologist, because this is sort of outside my scope. Even though it's head and neck, I would get some help on this case. So I actually like this article. So I've given you the reference here. It's Dr. Krishna. And it was out of a 2010 journal. So these are the immunohistochemical patterns for all of these metastatic cancers. And that can be your helpful. So you can do CK7, CK20 panels, and then there's specific things like PSA and Amaker for prostate. RCC, PAX8 will help you with renal cancers, because some of those cancers, like renal cancers, won't stain for any high molecular keratins, right? That's the problem. They'll be negative for both, and it doesn't help you. So don't rely just on your AE1, AE3, because AE1, AE3 won't stain for renal cell carcinomas, most subsets. Okay, second intracranial mass I want to show you is an intracranial mass that I'm showing you because it's A, it's very common, and B, it's one of the tumors that I've at least seen once or twice show up in the sinonasal cavity as an extension. So the first thing is I've got someone as an oxyphilic tumor. When I look at it, it's kind of swirly and whirly, and there's some hemorrhage. So the next thing is I have what look like sort of almost epithelioid cells. They're somewhat plump. There's some blood vessels in here. Okay, so I've got sort of this epithelioid tumor with blood vessels. And in other areas, I have these, well, I'm going to save the word. I'm not going to tell you what the word is yet to describe this, because when I show you the diagnosis, you'll understand why, right? Other areas, are they getting kind of nested? Well, they're not. They're actually spindle. So I've got epithelioid and spindled type morphology with these swirls and whirls on low power. So I'm thinking, what tumors look like this? Well, my first thought is in the soft tissue, this is almost has this dense collagen of a solitary fibrous tumor. So I would ask my learners, okay, what is your list of lesions that have both sort of epithelioid and benign kind of spindle cell looks that look a little bit like solitary fibrous tumors? And this turned out to be, the word I was looking for are meningothelial whorls. And so this ended up being a WHO grade 1 meningioma. Now, we are probably not the people to sign these cases out. This is somebody probably for a neuropathologist to sign out. But I'm showing you this because meningiomas can perforate based on their location into the sinonasal complex. And the other lesions you'll see is there are psammomatoid calcifications in some of these meningiomas that will make them look like fibroosseous lesions, right? Psammomatoid ossifying fibromas, which can also appear right in the sinonasal complex in young children. So meningiomas are one of the tumors I think we need to be at least familiar with. The other thing we need to probably be familiar with is nasal glial heterotopia, right? Things extending from the brain down. So I've showed you, right, a metastasis. I've showed you an extension potentially of a meningioma into the craniofacial complex. And then I'm going to show you one more intracranial mass that has a sort of a lot of background debris and hemorrhage, but I'm going to show you this very cellular tumor. it's coming out in fragments. So that makes it challenging. So this was not one of my cases, but what I want you to draw yourself attention to is now I'm starting to see some nests of bluish cells, and I'm starting to see some conglomerations of some oxyphilic type cells. And what I want you to start noticing is that the nuclei are somewhat round. They don't have meningothelial whorls. The other areas have somewhat of this more amphiphilic sort of cytoplasm. And then other areas start to have a combination of oxyphilic and more amphiphilic cells with this sort of hint of maybe these are starting to have a salt and pepper appearance to them. And then other areas you'll see have nests of very small round cells with this intervening combination of different kinds of cells with almost kind of a very creamy kind of pink. Again, I told you it's an intracranial mass, sort of a neuropil type structure. And then in other areas, you can see very oxyphilic cells, and you can see somewhat more amphiphilic cells, and they're starting to form little conglomerations. Okay, so what kind of tumors am I looking at? So we can do some stains on this. So you can do it's in the brain, you can do some nerve stains. And because it has little nests, we did some neuroendocrine stains in this, and it shouldn't surprise you that this turned out to be a pituitary adenoma. It was a little bit messier, but the pathologist did a reticulin stain, and you had a loss of reticular network. So why am I showing you pituitary adenomas? Because number one, they're accessed often through the sphenoid sinus, and they can also extend, right? Where is the sella turcica? It sits right above the sphenoid sinus. So now I've shown you a metastasis, I've shown you an intracranial primary brain tumor meningioma, and I've shown you a pituitary adenoma. And I've seen pituitary adenomas. It's only happened twice, but I've gotten functional endoscopic sinus surgery for somebody who has polyps, and they knew that the patient had a pituitary adenoma, so the surgeon did the surgeries together. And so I'm now staring at, I'm staring at polyps, but I'm also staring at a pituitary adenoma. And I ended up having a general pathologist sign that case out for me. And she says, you have the diagnosis right, but I thought it was outside my scope, and for legal purposes, I wanted to have a general pathologist involved. So you can have these tumors. Okay, so I did mention solitary fibrous tumors, and this is the conundrum, because if I didn't give you a location, then how would I know where I'm at? If I didn't tell you I was in the brain, and I can show you solitary fibrous tumors that can have sort of like this epithelioid appearance, and I can show you meningiomas that have a spindle-celled appearance. So what I've learned recently is probably the first stain you probably do on any of these is a STAT6. Because if you have a STAT6 plus or minus BCL2 that are both strong, you have probably a solitary fibrous tumor. Your proof then becomes the STAT6 mutation. That's going to be absent in a meningioma. But what you're going to have in a meningioma are EMA and some of these hormonal type receptors like PR, which will be absent in solitary fibrous tumors. So try to picture, could you have a solitary fibrous tumor type tumor in a sinonasal complex that could extend to the brain? Yes, you could. Could you have a meningioma that extends into the sinonasal complex? Yes, you could. So you really don't necessarily know, but by doing a short immunohistochemical panel mixed potentially with a gene that we know about. And again, now I think, how do these immunohistochemical stains arise? They arise because somebody finds a gene, and then people in laboratories find a way to take that gene and make a stain out of it. That's how these things happen. Sometimes they find the stain by finding the gene. So if you're uncertain, because these tumors can look similar, this is how you can tease the two out.